Good evening, everybody. On behalf of the Ceylon College of Physicians, you all are welcome to the 8th session of the Peer Learning Periphery to the Fore 2023 online case discussion by physicians away from the center. My name is Dr. Rohit Amaravitarana, the moderator of the today event. We know that the physicians working in outstations with limited resources have evolved excellent clinical skills in patient management. So there is a lot to be learned from them. Peer Learning Periphery to Fore is a platform for the physicians who work away from the center to share their knowledge and experience with others. In this session, two physicians present and discuss clinical cases in 1 hour period. Today, we have two consultants from DGH Dambulla and DH Madirigiri. At the end of the both presentations, we will discuss the questions. Please send your questions to Q&A box. First, let me to introduce the first speaker today, Dr. Jegavanthan Arul Kumar, consultant cardiologist, DGH Tamil. Dr. Jegavanthan Arul Kumar, MBBS, Peradeniya, MD Colombo, overseas training as a cardiology interventional fellow at University Hospital, Sussex, UK. He has local and international publications in the field of clinical, echocardiographic, and interventional cardiology, and has special interest in preventive cardiology. He is going to talk on a young patient with chest pain. Over to you, Dr. Jegavanthan.
Thank you very much, Dr. Rohit. So today I'm going to talk about patients with chest pain and also with some acute symptoms like becoming acutely breathless. So these presentations can happen in on a daily basis in an emergency situation. So the scope of today's lecture is actually to discuss an index case where I'll be concentrating more on the findings and how we have proceeded there. And also a couple of more cases to highlight the importance of bedside assessment, bedside sonography, in other words. And then I will move on to say the issues that we encounter in the resource-limited peripheral hospitals, and then also explore a few possibilities as to how we can overcome these existing shortcomings. And then finally, we have a discussion and also have a Q&A session. So moving on to the first case, which is the index case for discussion today, is a lady in her late 30s presented with central chest pain for about a week. And also she had progressive shortness of breath, which lasted maybe for about a month. And then on presentation, she was agitated with low normal blood pressure. She was tachycardic with a harsh systolic and a faint diastolic murmur. The bloods were immediately sent and the ECG is shown here. And as you can appreciate, there's a sinus tachycardia, but nothing towards abnormality here. And fortunately, since the ultrasonographic machine or the 2D echo was available, we did a bedside assessment. And this is what it showed. So to make the interpretation easy, I have actually shown a diagrammatic illustration of what we are looking at. So this is an inverted image of the heart where we see the ventricles on top and the atria at the bottom with left and right orientation in the same way. And now I will play the video and you can readily appreciate the gross abnormality there. So there's a huge mass which is occupying the LA. And also this mass is trying to, get its way into the left ventricle. And you can appreciate the size of this mass. So I'm sure all of you can readily appreciate the video and come to a diagnosis here. So the still image shows the extent or the size of this mass, as well as if you focus on the second picture here, where we have looked at the right ventricle also. there's significant tricuspid regurgitation, meaning that there is elevated pulmonary pressures as well in this patient. So the unifying diagnosis here is cardiac myxoma, and in the presence of a bedside assessment, the diagnosis was readily made. Otherwise, it would have taken a lot of time for us to arrive at this diagnosis. So the cardiac myxomas account for about 40 to 50% of the primary cardiac tumors, and approximately 90% are solitary and pedunculated. And most of them are in the LA, but few are in the right A as well. And as you all know, this is most of the time they come sporadic, when about 10% there is a familial inheritance, where it follows an autosomal dominant trait. Few more words on myxoma. Of course, we are discussing this index case today. So the mobility of the tumor understandably depends on how length the stalk is, as well as myxomas are typically benign, but local recurrence do occur if the resection is incomplete. And then sometimes these myxomas exhibit this tumor embolization phenomenon, which we will come later, as well as they can, of course, due to this prolapsing effect, they can disrupt the valve leaflets, like mitral valve leaflets. And these patients, few of these patients can have some tachyarrhythmias like atrial fibrillation. And interestingly, there's production of interleukin-6, which can cause some phenomena like Raynaud's and constitutional symptoms. So myxomas are notorious to cause embolization, and this can affect any major artery. So TIA, stroke, retinal artery thrombosis, and the list goes on. And interestingly, if there's a presence of ASD, like an intracardiac shunt, paradoxical emboli can also occur. So what's the treatment? What's the rush in diagnosing this condition is because treatment of myxoma is by surgical resection, and the surgery should be performed as soon as the diagnosis is made. And mini thoracotomy with robotically assisted surgery is emerging in developed countries. Since these myxomas are notorious to cause cerebral emboli and infarctions, there's always a debate if the patient comes with myxoma and a CVA, what's the time to operate her. And now interestingly, there are studies coming up to say, even with infarction, if it is in a hyperacute phase, like let's say 28 to 40 hours onset of an infarct, these patients can still undergo surgery safely. All right, we will move on to the second case, and from here onwards, we'll be moving quite soon with just 1 or 2 slides to discuss each case. So the first case I described was actually a patient who was very fortunate because we diagnosed her on a Thursday, and by Saturday she was operated. But this patient is not very I would say not very fortunate. You can see the morphology is more or less the same, but here the diagnosis was entirely different. So this patient actually had an intracardiac extension of a primary lung tumor via the left pulmonary vein. So although the appearance was more or less the same, the pathophysiology and the tumor was completely different, as seen in this CT imaging. So small cell lung cancers, although they are very rare, can cause intravascular cancerous thrombus extension through pulmonary veins. All right. Moving on to the third case, this is again an interesting finding on the echocardiogram, where you can appreciate there is a bulge in the interventricular septum, and this tumor, through the presence of a small either a PFO or a septal defect, has extended into the right atrium as well. So this is a tumor which is occupying both the LA and the RA. All right. So moving on to the fourth case. So I'm illustrating these cases to, just to depict how important the bedside imaging when it comes to quick decision making. So this is a young boy coming with fever, cough, and a left-sided pleuritic chest pain. So by the history itself, I think you would have probably narrowed down the diagnosis. And so there was a sharp medical officer in the ETU who managed to get some beautiful images. And you can see that behind the heart, there's an additional shadow. And I have also depicted here on this diagram to make it easy for you to follow. And this is actually not the pericardial space, rather the pleural space. And you can see there's a large pleural effusion with exudative material in it. So the diagnosis was readily made. So we don't even have to wait for a chest x-ray in this patient. So this was a patient who was coming with a pneumonia with an exudative effusion. All right. So fast scans has been traditionally performed when we suspect there is a trauma with visceral injury. So this patient was a trauma victim with large amount of free fluid in the abdomen. And of course, we have done a fast scan. And then this diagram again illustrates the presence of free fluid, which is readily appreciated between the right kidney and the border of the liver. So of course, if we do the scans quickly, we can do timely referral to the surgeons. So this is case number 6. Again, a very interesting case, I would say, but unfortunate from the patient's perspective. A 40-year-old man coming with severe retrosternal chest pain and backache with inferior ST elevations in the ECG. So understandably, we would have rushed to do thrombolysis here. But the physician there was quite suspicious and reluctant to give thrombolytic treatment because of the presence of wide pulse pressure and a murmur. And of course, as you all think, the diagnosis was quite certain and readily made on the echocardiogram, where if you compare with the normal diagrammatic illustration here on the right upper corner, the aorta is hugely dilated, and I'm sure all of you can follow that. And as I move on to the next picture, you can appreciate that not only there's dilatation, there is presence of severe aortic regurgitation, which is depicted by this color flow, where this red color flow with the turbulence show the presence of severe AR. Therefore, the diagnosis here was actually a Stanford type A aortic dissection, which was actually extending into the coronary ostia, so that there was concomitant inferior myocardial infarction. So readily, this patient was transferred to a cardiothoracic center, and he was operated on the same day night. All right. We will move on to the next patient. Again, a very young patient who was coming with chest pain, fever, and chills. And then on clinical examination, he was having right heart failure with a harsh pansystolic murmur. And if you compare the video with the still image onto the right, you can again appreciate that the right-sided chambers are dilated with destruction of the tricuspid valve leaflets. And also, I wonder whether you can appreciate there's a presence of a large vegetation on the tricuspid valve leaflet. So the diagnosis of tricuspid valve endocarditis was made here. And this patient, again, has all the parameters which will fulfill to refer for a surgical intervention, such as right heart failure, presence of severe TR, and a vegetation which was more than 2 centimeters in diameter. And then, so I will move on with the cases quite quickly just to illustrate the importance here. And this case number 8 is a elderly man with hypotension that was refractory to inotropes, and he was having oliguria. And I am sure all of you can appreciate what's abnormal here. If you compare with a normal beating heart, this patient's heart is almost in a standstill like. So it's very poor LV contraction. And here, some of the areas of the left ventricle are so much thinned out if you compare with the still image. So this is a patient with very, very advanced, severe systolic heart failure. So that's why he was hypotensive, and because of renal hypoperfusion, he was having oliguria. Again, a patient who was refractory hypotension, and you can appreciate how large his heart on the chest X-ray. And despite this hypotension, he was not having the reflex tachycardia. He was bradycardic. Why was that? He was having a large pericardial effusion due to hypothyroidism. And you can appreciate how large this effusion when compared to the heart and the mediastinal border. So bedside sonography is also important to assess the status of fluid volume, and it is a surrogate marker to assess the central venous pressure. How we do that? We quickly assess the diameter of the IVC and also its collapsibility with respiration. So with that, we can get an assessment of how bad or how high the intravascular volume status is. Okay, with those 9 cases, I will just move on to the next part of my lecture where I highlight the importance of bedside assessment. So in an emergency setting, every minute delay will take the patient away and away from your care. So when patient care can't wait, suppose in an emergency, point of care ultrasound, we call it focus in shortened form, help the physician to make a quick and accurate diagnosis and to make the clinical decision easy. And understandably, it's very affordable and non-invasive. And this important thing is that the focused ultrasound can be an extension of the physical examination. So when do they become very useful? In any hemodynamically compromised patient, understandably, and in trauma victim, the fast scan that I showed. And then when the presentation is bizarre, or when there's a diagnostic dilemma, you think whether this is a STEMI, but your colleague thinks this is dissection. So when there's a diagnostic dilemma, the scans become very handy. Or if there's treatment failure or deterioration of clinical parameters despite initiation of treatment for a presumed diagnosis. Post-resuscitation, yes, very important. And also in emergency procedures like aspiration of pericardial effusion, you can do with ultrasonic guidance. All right. So what are the limitations that we encounter in these resource-limited peripheral hospitals? So when it comes to sonography, we have very few machines available. And then since this repair cost has gone sky high now, if they are defective, these are not readily replaced. So we become increasingly resource poor stations. And then, of course, we need to share with different fields of expertise. But sharing is, of course, not a problem. But then what happens is that invariably the patient gets delay in obtaining the service. And then the other important thing is because most of the consultants and clinical expertise have to cross-cover different hospitals these days, unavailability of resource personnel to get real-time opinion is also a problem now. And then the other important thing I want to stress is that lack of awareness or lack of enthusiasm. There is a deteriorating patient in the ENA, there is a machine on the standby, but the doctors are not very either they are not trained or they don't have the enthusiasm to at least scan the patient's abdomen to see what's going on. And then, of course, outdated machines and software. This is again an increasingly becoming a problem now. Because with advancing technology, in tertiary hospitals, we tend to we get crystal clear images of mitral valves, the septal defects and things like that. All these facilities are lacking in peripheral hospitals. Okay, how we can explore the possibilities to overcome these existing problems? So one of the main way of doing this is to increase the awareness among practitioners about the usefulness of bedside assessment by sonography. And also, it's important to encourage self-learning and peer learning by which the doctors working in A&E, the HDUs, the ICUs can increase their level of expertise so that they themselves can do some basic sonographic assessments, especially when there is an emergency presentation. And then the other important aspect is the portable units. Utilizing portable units are very useful to shuttle in between units rather than trying to transfer unstable patients towards a stationary machine. So I think when it comes to annual utilization of funds and allocation, I think we should focus more on trying to get some portable units by ways and means of convincing the administrative aspects. And then the other thing is to have end of day feedback, especially in ETUs, we can practice that. We can have feedback discussions at the end of the day and see how useful these bedside assessments have been to improve patient outcome. As clinicians, we have the responsibility to enrich the knowledge of colleagues and co-workers. So I think conducting CMEs and encouraging self-learning has an important point here, because the sonography actually has a learning curve, especially probe orientation and probe positioning will have a bit of a learning curve where the practice only will make it perfect. So I think when it comes to that aspect, I think as clinicians and consultants, we have a responsibility to encourage peer learning and also self-learning among colleagues and junior colleagues. But of course, once the image is obtained, rest of it is very easy, because interpretation with the now technology like mobile phones and laptops, interpretation can also be done remotely. So we don't have to be on site to make the interpretation. All we need is to get some good quality images. And of course, once the emergency is tackled, detailed scans can be done later on. All right. So am I bluffing, or is there any evidence to suggest bedside imaging positively affects patient outcome? Yes, there are numerous studies to say that bedside assessments by means of ultrasound invariably increases the patient outcome. Even a 4-day training has improved as excellent detection rate for pleural effusion and interstitial syndrome amongst trainees. So, and there are numerous meta-analyses. There are a cohort of more than 5,000 patients were involved, where they had assessed the point of care ultrasound in patients with dyspnea, and they found that the clinical outcomes were better. It reduced the time to diagnosis, time to treat, length of stay was shorter, and then it also improved the rate of appropriate treatment. That is what is very important. And also, there had been systematic review where they had evaluated the point of care ultrasound on the clinical outcomes of resource poor settings, similar to applies to us as well. And then it also, they identified that it changed there was a drastic change in diagnosis and patient management positively. All right. So to wrap it up, I highlighted few common and uncommon cases which can present to the emergency department with chest pain, breathlessness, with hemodynamic instability. And I stress the importance of bedside imaging as an extension of physical examination. So we take a targeted history, a targeted examination, and then we do a targeted bedside imaging so that the diagnosis is easily and timely made, so that the appropriate treatment can be easily started. And then I also suggested that the focus is very, very non-invasive and cost-effective. So it can timely replace the traditional methods like CT scans and MRIs, which are of course expensive and limited to in our setting. All right. What are the take-home messages? Point of care ultrasound prevents delay in patient management, therefore enhances patient safety. Since time is life, bedside imaging understandably saves patient lives. Focus is now confined to few hospitals only, so it's our task as physicians and CCP consultants to expand it to the entire island. And then possessing this skill is handy in an emergency because it's life-saving. And also, I have observed that there's an increasing trend now in overseas to incorporate focus in the training of the first 2 years of medical curriculum itself. So they do the examination, and end of examination, the students are encouraged to do a focused bedside ultrasound if they suspect there's a gross abnormality. Thank you very much. So I would like to take this opportunity to thank the CCP, Dr. Rohita, my trainees here as well as overseas, and all the patients without whom this discussion would not have been possible, and of course today's participants. Thank you very much.
Thank you very much, Dr. Jagavandan, for very interesting and informative presentation on the importance of bedside assessment by sonography, for especially patients present with chest pain. It should be very, very useful presentation. Thank you once again, Dr. Jagavandan, and we'll come for the questions at the end of the second presentation. And let me introduce the next speaker today. The next speaker is Dr. SDN Senadira, consultant physician from BH Madirigiri. Dr. SDN Senadira, MBBS Colombo, MD Colombo, overseas training at Dorset Country Hospital, NHS Foundation Trust, UK. He is going to present on investigating a patient with anemia and PUO, an uphill battle for a peripheral physician. Over to you, Dr. Senadira.
Thank you very much, Dr. Rohita, for your kind introduction.
Okay.
So my topic is, good evening to everybody. My topic is investigating a patient with anemia and pyrexia of unknown origin, an uphill battle to a peripheral physician. I selected this particular topic because of two reasons. First one is to discuss a rare clinical condition, and the second cause is to highlight challenges faced by outstation physicians when they investigate patients like this. So my patient is a 46-year-old female from Madirigiri. She's a mother of 2 children. She's a housewife and her husband is a farmer. She had a past history of well-controlled type 2 diabetes, which had been diagnosed for preceding 2 years. So I will tell you about the history with the timeline. In 2022 December, she had first developed right side abdominal pain, which was described as an intermittent vague type of non-colicky abdominal pain, and she mainly felt it over right iliac fossa and loin regions. She had no associated urinary symptoms and no alteration of bowel habits, and she had no fever or loss of weight. And also she has had normal, regular menstrual cycles. Because of this abdominal pain, this patient has gone to few doctors in the area, and they had done basic investigations. Out of those basic investigations, UFR had shown microscopic hematuria without any evidence of active sediments. And because of microscopic hematuria, those doctors had requested ultrasound examination, and ultrasound scan had revealed mild pelvic system fullness on right side. In addition to UFR, the full blood count had shown microcytic anemia, but no much attention was given to that. Because of right-sided loin pain, microscopic hematuria, and ultrasonic evidence of pelvic axial fullness on right side, patient has then gone to a urologist, and urologist team had done CT IVU in January 2023. That was also not much informative apart from extrarenal baggy pelvis. Then nearly 4 months later, this patient came to the medical ward for the first time. And at that time also her main complaint was intermittent right-sided abdominal pain. But at that time also she had no fever or any alteration of bowel habits. But importantly, she had lost nearly 7 kilograms over preceding 2 months. And it was also associated with significant mild loss of appetite. Importantly, she had anemic symptoms, but didn't mention any obvious bleeding manifestations. She had no respiratory symptoms. So during examination, she was severely pale, but there was no icterus. And she had mild tenderness over the right loin, but there were no palpable masses in the abdomen. There was no organomegaly, there was no any lymphadenopathy as well. The per-rectal, per-vaginal examinations were normal. We couldn't detect any melena. There were no any adnexal masses. The respiratory system and cardiovascular system examinations were also unremarkable. She had no any malabsorption features. So depending on this history and clinical examination alone, these were our differential diagnoses at that time. So this could be a gastrointestinal bleeding, which can be due to malignancy, inflammatory bowel disease, or chronic GI infections such as tuberculosis. And also this can be a primary hematological malignancy, even though the abdominal pain, which cannot be directly explained by hematological malignancy. So keeping those differential diagnoses in the mind, we did these investigations. So biochemical investigations showed microcytic anemia. The hemoglobin was 6.2, and interestingly, there was thrombocytosis also. The platelet count was 705,000, but her WBC count was normal, and ESR was 110. And her blood picture showed iron deficiency anemia and reactive thrombocytosis, but there were no abnormal cells in her peripheral blood film. The LDH was 312 and retic count was 1%, and her ferritin was low, confirming that she is iron deficient. And then we did the ultrasound scan of her abdomen. And interestingly, that showed aneurysmal dilatation of her terminal ileum, which was measuring about 4.3 to 8.5. But at that time, there were no any paraaortic lymph nodes. So the radiologist suspected whether this could be a small bowel lymphoma. So with those investigation results, we could narrow down our differential diagnosis list. So this can be a bowel malignancy, can be a lymphoma, or can be something else. And also inflammatory bowel disease, particularly Crohn's disease, can present in a similar way. And tuberculosis, GI TB can also give rise to these kind of presentations. So keeping those differential diagnoses in the mind, we did chest X-ray, MARTO testing, and sputum AFB, but all were negative. Then we did the CACT of the abdomen. And CACT abdomen showed an irregular circumferential wall thickening in the long segment of the distal ileum and aneurysmal dilatation of the same segment. But at that time also there were no any identifiable paraaortic lymph nodes or mesenteric nodules. So again, the same suspicion whether this could be a small bowel lymphoma. Then we decided to do a colonoscopic examination. It was initially done at base hospital, but due to technical problems, we had to repeat the test at District General Hospital also. They could visualize up to the terminal ileum, and they noted prominent Peyer's patches of the distal ileum. But apart from that, there were no any macroscopically visible ulcerations or any other abnormalities. So colonic and ileal biopsies were done at that time, but unfortunately we had to wait nearly 1 month until reports are available because at that time there was no pathologist at AGH Colonabo. So during that period, so within that 4 weeks period, she developed intermittent fever, which was going on for 3-4 weeks. It was described as a low-grade fever, evening fever with constitutional symptoms, and this associated with a significant loss of weight and loss of appetite. And she was anemic recurrently. She required blood transfusion. and her PSR was persistently high, which was always above 100, and LDH was 310. So during that 1 month period, we gave her supportive care, and in about 4 weeks, we received colonoscopic biopsies, but that was not conclusive. There was no evidence of any lymphoproliferative disorder, or there was no any evidence of granulomatous inflammation, no any neoplastic features. Then, after discussing with our surgical colleagues, we decided to proceed with diagnostic laparoscopy. So laparoscopy was done, and then we detected a proximal ileal level tube, which was attached to the anterior abdominal wall as well as to the bladder. Then, following 2 days of laparoscopy, this patient developed acute abdomen, and then we had to go ahead with emergency laparotomy. And during laparotomy, our surgeon noted that tumor is actually arising from the jejunum, and jejunum perforation was noted. Then jejunal resection was done, and she was given ITU care at District General Hospital following the surgery. Then we received the excision biopsy, and that confirmed the diagnosis of non-Hodgkin's lymphoma, and it was categorized as high-grade lymphoma. So thereafter, we did another CT scan to stage her disease. So it was classified as advanced disease with multiple centric and paraiotic lymph nodes. The chest CT was normal. So then we referred her to oncologist, and currently she has completed a course of chemotherapy, and she's awaiting another CT scan next week. And at the moment, she is doing okay. And because of her advanced disease and tumor type, her predicted 5-year survival is, I think, around 50%, according to oncology opinion. So these are the key points of this clinical scenario. A middle-aged female with chronic right-sided abdominal pain who developed fever subsequently, and she had recurrent transfusion-dependent anemia with reactive thrombocytosis, and her ESR was persistently over 100. So ultrasound scan played the crucial role during the initial workup. That is, the investigation which triggered further imaging and other investigation. So as you may have already noted, there is a significant delay. Definitive diagnosis was arrived after 7 months from the symptom onset. So you may wonder why this delay is. So I would like to elaborate on that. The first thing is the disease itself is a diagnostic challenge. Depending on the site and the type of the tumor, the presentation is heterogeneous. And radiological findings are also not specific. As I already mentioned, even Crohn's disease can radiologically appear in the same way. And also, peripheral hospitals, most of the time, we do not have facilities to do small bowel visualization. We don't have small bowel capsule endoscopy or double balloon endoscopy. Methods are not available at our peripheral hospitals. So that is a disadvantage. And particularly, I would like to highlight this: at peripheral hospitals, we don't have everything under one roof. I mean, investigation facilities. These kind of patients need a number of investigations and a long way of follow-up. The process of investigating and arranging investigations take time. For example, if I send a blood picture today, I will not receive the report by next day or day after. We have to send the sample from the base hospital, then they have to do it at the base district general hospital, and then we have to receive the report. District general hospitals, they drain a number of base hospitals. They receive a huge amount of samples. So it is a time-taking process. And nowadays, because of this crisis situation, as our Dr. Jayakantan also mentioned this, lack of some subspecialties worsen the delay. Because if we do not have the pathology report, such as in our case, we can't proceed beyond that. And most of our poor
patients, they can't afford these investigations outside. So we are stuck without, we can't proceed beyond that. And most of these patients, their educational level is not that good. Therefore, whenever there is a delay or whenever they feel that, but their impression is we are not treating, so they tend to deviate for other alternative treatment options. So there's a high chance you missing the patient halfway through. Pointing out all these factors, can we transfer all these patients to district general hospitals? I don't think so, in my opinion, because they are also most of the time workload is very high, and we are also consultants, so we should also be able to manage patients, and we should also be able to follow up our patients. So sending each and every this kind of patients to district general hospitals is not a solution. So these are the things I would like to discuss with you all also. So few things about gastrointestinal lymphomas. Primary GI lymphomas are rare, which accounts for less than 0.5% of all GI malignancies. And GI tract is the commonest extranodal site for lymphomas, and majority of these lymphomas are non-Hodgkin's lymphomas. Stomach is the commonest site, which accounts for 75% of tumors. Small bowel, only 9%. There are a number of well-known predisposing factors, such as immune suppression or immune deficiency, autoimmune conditions, autoimmune disease itself, as well as immune suppressive treatment given to autoimmune diseases can predispose to GI lymphomas. H. pylori infection and inflammatory bowel disease. Those are some of the well-known predisposing factors for GI lymphomas. As I already mentioned, the presentation is heterogeneous depending on the site. This can produce abdominal pain, diarrhea with malabsorption, constitutional symptoms, ascites, bowel obstruction, bleeding and anemia, and even bowel perforation can happen, such as in our patient. So the diagnosis, these are the tools which can be used. Endoscopic examination and biopsy can be done at the same time. In small bowel capsule endoscopy will be useful is a useful tool to visualize the small bowel, but the disadvantage is we can't take biopsies. CT scans, PET scans, and certain other endoscopic techniques can be utilized. And if there is no access from those methods, we can go for exploratory laparotomies and biopsies. Treatment modalities depend on the tumor type and subtypes. So that needs pre-treatment evaluation and staging. So surgical options are there, and also chemotherapy and immunotherapy and radiation methods depending on the site and the type of the tumor. So that's all, and thank you very much. And I would like to thank CCP and Dr. Rohit for giving me this opportunity, and also all our consultants who supported me in managing this patient at Base Hospital, Madirigiri. Thank you very much.
Yeah, thank you very much, Dr. Senadira, for very interesting and informative presentation on GI lymphomas and explaining very interesting case presented with abdominal pain and then end up with the GI lymphoma. So now we are coming to the Q&A sessions. Let me to check Q&A box, and if you have any questions, please send to Q&A box. We couldn't get any questions now in the Q&A box. Yeah. May I ask a question from Dr. Jagavandan?
Yes.
Actually, thank you very much for your very interesting presentation, especially you discuss the importance of doing sonographic evaluation of patient at bedside in especially emergency situations, right? So, Dr. Jagavandan, can you please you explain this with the examples? Also, a lot of examples you discuss. So, my question is, if you summarize, so if we have a patient with chest pain, so what are the indications for chest pain patients go for the bedside evaluation with ultrasonographic evaluation? Dr. Jagavandan.
Very good question. So I actually put up one slide there where I highlighted which kind of patients will be more benefited by doing a bedside assessment. So suppose if a patient comes with chest pain and then you do a ECG and then it clearly shows an acute coronary syndrome. Of course, you would be doing a targeted physical examination and a quick history. So if everything fits into an acute coronary syndrome, yes, absolutely no problem. We can initiate the ACS pathway and go accordingly. That's what the standard practice is. But the problem comes is when you have kind of a very bizarre presentation or some physical signs which point towards a very gross abnormality. For instance, where I showed that was a real case which we came across in Dambulla. So the sharp physician noticed that the pulse pressure was quite wide. And that's what made further auscultation. And then, of course, this diastolic murmur in aortic regurgitation, sometimes it's a giveaway murmur. It's an early diastolic giveaway murmur. So sometimes it can easily be missed on auscultation. So these kind of very subtle physical signs will give a clue as to, something else is or something in additional is going on in these patients. And the other important thing is like any hemodynamically unstable patient. So of course it could be a sequelae to a AMI, but if you find that, the clinical presentation and the findings that you see are not really matching, if there's a mismatch, I think bedside assessment comes very important. Not just in chest pain, but also in any other presentation like dyspnea and things like that, it becomes very useful.
Okay. Thank you very much, Dr. Jagavandan, for very interesting, the discussion. And also, Dr. Senadira, I like to ask one question from you, Dr. Senadira, and regarding your case, when you have no clue for the diagnosis, then you all discuss and decide to do laparoscopy.
Yeah.
For that patients with abdominal pain. So that what is the reason why you go for the laparoscopy straightforward? Because is there any clinical things to suggest to go for the laparoscopy? So why didn't you do CT there?
Yes, Dr. Rohit, we initially did the colonoscopic examination, but colonoscopy as well as colonoscopy macroscopically didn't show any abnormalities, and microscopically also it was like normal. And ultrasonically and CECT abdomen showed like a mass, like actually a mass which was attached to the small bowel. The origin was not very clear. So because there is no any other access, we discussed with our surgical team, and then we decided to go for laparoscopy with the objective of taking samples also for histological assessment.
The reason, right? Okay. Also, Dr. Sudhir, there's one question from the audience. Also, they ask how you can explain hematuria for your patient.
I think it cannot directly be explained by lymphoma alone. Maybe something which is not related, and the subsequent UFR reports didn't show persistent hematuria. So I think it is not relevant to the initial presentation. Because of abdominal pain and microscopic hematuria, the initial pathway got deviated, I think.
Okay. Thank you very much, Dr. Senadira. And so, thank you very much. So, in the absence of any more questions, let me to wind up the sessions today. So first, I would like to thank two speakers, Dr. Jagavandan Arul Kumar and Dr. Senadira, for accepting our invitation and share their experience with us. Thank you very much once again. And also, I would like to thank CCP staff, audiovisual team, Mission Manalina, and sponsor Merck Pharmaceuticals for their continuous support, and all virtual participants who joined with us today. Thank you very much.